Yepa, ala yepa, odo. O odo na. Ko mo kuna bia yepa mo. This is my Sunday. I saw it. Other person will be long. Wait. Can I so I hope you so talking. What kind of what's my father? Okay, I'm a couple.
Sister Nancy Addy, please mute yourself.
Yeah, good evening to you all, please.
Good evening, sister.
How are you, please?
You are doing well, oh. Thank you, sister.
Please, let's start with the presentation. I think group 5, right? Group 5 is the one presenting. So let's start. Petram.
Yes, sister.
Petram.
Yes, sister. Please, I'm here.
Yes, please start.
Okay, sister.
So if I'm on mute, don't think I've left you. No. Okay.
Okay, sister.
So please start presenting. You have 20 minutes plus 10 minutes for questioning and then listening. So be fast about it. And then Petram, I have no
Yes,
listen
sister.
here. So you write the names of the listen for me. Those presenting.
Yes, sister.
I'll take it from you. Okay.
Yes, sister.
Okay. Thank you.
Okay. Group 5, please, you presented last week, or please, any member from Group 5?
Yes,
You
said last
presented
week
last
on this
Yeah. So
on
then
Sunday.
Group 6. Okay, thank you. Group 6. Please, Group 6. Tamale Center.
Hello, Miss Petram.
Yes, please.
You call Tamale Center?
Please, Group 6, or
No, Group 7 rather.
the hypoglycemia is not for Tamale Center.
No.
Can it be must it
Harris.
be necessary that group 6 should start? Any group that is ready can present, or
Okay, if you are ready, then present.
so I think that one will be better. Now we are wasting time.
Please, you can start.
Please, good evening. Please, I'm Phyllis, and we are presenting on inborn errors. And need to please go down small. Down. Okay.
Please, which group is this?
7.
7.
Yes. Okay, so group 7, we are presenting on inborn errors of metabolism in a newborn, presenting with hypoglycemia and bleeding. So our case scenario says that a 3-day-old baby presents with poor feeding during this hypoglycemia, bleeding from umbilical stump. Question: what are your immediate actions? Would you refer? So at the end of our presentation, we'll be able to present to students the definition for inborn errors of metabolism, then identify causes of neonatal hypoglycemia, recognize abnormal bleeding in newborns, identify red flags, and then understand when urgent to refer. So we are saying that inborn errors metabolism is a genetic condition present at birth caused by absence of specific enzymes, which leads to the accumulation of toxic substances and the inability to produce glucose, which affects liver functioning and is mostly autosomal recessive. So with this, we are saying that when this happens in newborns, it's as a result of absence or deficiency of enzyme in the body. And it also affects the metabolism of carbohydrates, protein, and fats. So we are moving on to why midwives are important. So mostly it's a midwife who will be able to notice the errors in newborns when they are being born. So first is poor feeding. So because they are having a disorder in metabolism, it leads to poor feeding. And when there's a poor feeding, it also leads to lethargy, which is when they will become very weak. And then since they are not able to feed well, it also leads to hypoglycemia, which is low glucose in the body, lesser than 2.6 grams per deciliter. And then there will be jaundice and then bleeding. So we are saying that relating to the jaundice, because the liver is being affected, it's not able to process or store or release energy. And then when it comes to the bleeding aspect, we're also saying that inborn metabolism also causes severe liver dysfunction, which also disrupts the production of clotting factors. So when there's disruption of clotting factors, it also leads to bleeding. So when there is a bleeding in the newborn, it's very difficult to stop the bleeding. So we are saying that early detection also saves lives. So when you are able to detect this disorder in the newborn, and then if there's a treatment, it has to be started as soon as possible to minimize the effects on the newborn. We are moving on to the neonatal hypoglycemia. So we are saying that neonatal hypoglycemia is when there is a low glucose in the body, which is lesser than 2.6 millimole per deciliter. And the signs and symptoms of hypoglycemia in newborns are jitteriness, weak cry, poor feeding, hypothermia, seizures, and lethargy. So mostly, we are saying that mostly when a newborn is being born, when they are crying, you see that their feet, their legs, and then their arms will be shaking. But with this condition, they wouldn't be crying, they would just be lying there, but you see their hands just shaking without any cry. So that is the jitteriness. So it's a disorder that whenever you see it that way, you have to report or act quickly. And then we cry. So you see that whenever they are crying, their cry becomes so weak that sometimes you can't even hear their cry so well. And then poor feeding, because the liver and the other disorders in the body, they wouldn't be able to feed well. And also hypothermia. So since the liver is not functioning well, and then the glucose in the body is not able to metabolize well, so the body starts to lose heat, which leads to the hypothermia. And then seizures, because there's low oxygen in blood, leading to dysfunction of the liver. It also reduces the energy which is being sent to the brain for functioning. So it leads to seizures and then lethargy. So when all this happens, it also leads to lethargy, which is the weakness of the baby. Thank you.
Continuing from why hypoglycemia occur in inborn metabolic My name is Abdurazak Bintu. And one, we have inability to break down glycogen. So since the liver is not functioning well, it will be able to convert the glycogen into glucose for the body to use. And we have failure of glycogenogenesis. That's the same as the inability to break the glycogen into glucose. The body cannot make new glucose from non-carbohydrate. The body will not be able to switch to using the fats for energy or as energy if the glucose level is low. And then the ketone production too is affected. So the brain and body lacks alternate energy. And we have liver failure. Since most of the enzymes are not there, the liver is overworked. And at a point, it won't be able to work well, which will lead to the failure. And we have the baby cannot maintain blood sugar during fasting. So if the baby is starved for a long time, the glucose production and regulation is reduced. We have neonatal bleeding. That's abnormal bleeding of the umbilical stump. We have neonatal bleeding. That's abnormal bleeding, which includes umbilical stump bleeding. excessive heel prick bleeding. We have bruises. We have gastrointestinal bleeding. We have prolonged prothrombin time. We have bleeding in newborn. Bleeding in a newborn is never normal. So when we talk about neonatal bleeding, when you give birth, after you cut the umbilical cord, the bleeding is supposed to stop. But when you see that it's not stopping, the bleeding is coming more, then you need to seek for help. Or when there's small bruises, you see that there's more bleeding. Small thing that the baby will be bleeding more. So we say why bleeding occur in, and they said liver failure, reduce clotting factor production. Since the liver is having a problem, it won't be able to produce the clotting factors and VSK dependency factors. And we have platelets dysfunction. We have liver. The liver play a major role in clotting. Yes. We move on to importance.
We move on. Please let me take it from there.
Okay.
Stepping to please let me take it from there.
Please, you can continue.
Please, we'll move on to importance of inborn error metabolism condition due to glycogen storage disorder. So according to von Jett disease, several severe fasting hypoglycemia, which lead to enlarged liver, lactic acidosis, bleeding tendency. So according to von Jett diseases, we said this condition is it occurs rare when there's an autosomal recessive metabolism, which is caused by deficiency in glucosase phosphate enzyme complex, which lead to severe fasting hypoglycemia and then lactic acidosis in the liver. So when we come to the bleeding tendency, when already the liver is having there is liver failure or low platelet level due to the enlarged spleen. That's the low tendency during bleeding access. So we move on to importance of inborn errors metabolism condition when there's milk-related disorder. So classic galactosemia, it occurs after breastfeeding stage. So failure for the baby to vomit. The features are when baby have it difficult to vomit. That means it could be either excessive feeding due to overfeeding or sensitive due to milk protein or there is dysfunction in the gastroesophageal reflex. So move on to the jaundice. Already there is jaundice and then hypoglycemic, liver failure, bleeding, and then risks of sepsis. Sepsis occur due to inability of the baby's metabolism during milk secretions. Thank you. Amai Joyce.
Please, I'm Janet. Again, I'm continuing from important inborn error metabolism condition, fasting intolerance. That is medium chain acyl-CoA dehydrogenase deficiency, hypoglycemia without ketones, sudden deterioration, then risk of sudden death. And this makes baby worsens after missing feeds. That is when the baby is not being breastfed. Some of the red flag signs are immediate referral if newborn has persistent hypoglycemia, early jaundice within 24 hours, poor feeding, vomiting, enlarged liver, bleeding, and seizures. Immediate management of the hypoglycemia. If suspected, you check blood glucose. Initiate early feeding. If very low, IV 10% dextrose should be set up, and an urgent referral should be made. Do not delay treatment.
Janet, let me take from there. I'm Benedicta. Immediate management, that's bleeding. You have to also confirm vitamin K when given. Also, you have to administer vitamin K if not given. You have to check for the baby's vital signs. Urgent referral. You have to also refer baby when the condition is worsened. You have to prepare for possible blood products at hospital. We move on to the role of newborn screening. Many countries screen for phenylketonuria, galactosemia, MSID, other metabolic disorders. Also, early detection prevents brain damage and death. We then move on to the key
Let me take it
take-home
from
message. Okay.
Let me take it from Hanke. So the key take-home messages, yes, we should remember this. I'm Dadia Deborah. So one, it says not all hypoglycemia is due to poor feeding. And then bleeding in newborns is always abnormal, of which as midwives, we always know how important it is to always administer with care during immediately the child is born. Then we have IEM can present within the first few days of life. And then early referral saves life and then brain function. And midwives play a vital role in early detection because when a neonate is born, we always do head-to-toe assessment to rule out any abnormality or any deviation from normal. Then we come to the conclusion, which says inborn errors of metabolism may first appear as one, hypoglycemia, of which we always get to detect it by checking our RBS, and then other things that can lead to hypoglycemia. Then bleeding. Sometimes when we prick them, they bleed a lot. So if you apply a little pressure at the side of the tool, it stops. So if it doesn't stop the problem or the cord, the site of the cord, then we have jaundice. Jaundice can either be pathological or so we will be able to detect if baby is jaundice, not being able to breastfeed well. We can see, and sometimes we even educate the mothers on how to be able to detect when the baby is jaundice. Then poor feeding, when baby is not able to breastfeed very well or attach properly to breast. Then proper recognition and referral can prevent. So when we see this, maybe we those are the health centers. When we see this, and then baby is very weak and can't help itself, or mother helping it, then we refer. Then brain injury, then liver failure. because most of these things can make the baby's brain not to function properly when they grow up, and then liver fit will lead to liver failure. Please, you left the place. Step into. Okay, all right. Okay, and thank you. I'm Daddy Adebora.
Please, it's time for questions and contributions. The next group should get ready. Thank you.
Hello.
Well, are you done with the presentation?
Please, I want to add something about when Bintu was doing the presentation about the cord bleeding. Please, she mentioned that if the cord is bleeding, the woman must do something. So I wanted to add something about it. I want to how do I mean? I want to add, like, maybe if sometimes they clap the cord, but if it's still bleeding, I hope maybe that's what she didn't add. When they tie the cord, sometimes it still bleed, then they will come to the hospital or something like that. Thank you.
Like you see, my cousin, hey, your people, I was telling you, I was true. I didn't mean mute here.
Please, any question or contribution? If there are no questions, please, can you stop sharing so that the next group can start? Any group that is ready can start presenting. Thank you.
Mm. Mm. Good evening. Please, this is Akimodan Center. We are presenting on newborn resuscitation with practical. Our learning objectives. So by the end of our presentation, we'll be able to recognize the need for newborn resuscitation at birth. We'll define newborn resuscitation and we'll know the key aspects of newborn resuscitation, the equipment needed for newborn resuscitation, how to perform the essential steps of newborn resuscitation, the use of chest compressions and medications correctly, thermal management, and understand common pitfalls and troubleshootings. So we are beginning with the definition for newborn resuscitation. He said it is an emergency, time-sensitive intervention performed within the first minute of life to help newborn establish breathing and circulation and prevent brain damage or death. It is required about 10% of newborns who struggle to transition from fetal to independent breathing. So the key aspects. So the purpose for newborn resuscitation.
Please, let me continue. Let me continue from the key aspect.
Okay.
My name is Mavis Akese. So the key aspect of newborn resuscitation, one, we have the purpose. The purpose, we have to assist with the transition from using the placenta to breathing on their own. Hello.
Hi, continue.
Okay. So as I was saying, the purpose is to helping the baby to breathe on his or her own after the baby is born. Then the second one, we have initial steps. That is the first minute. The baby is placed under radiant warmer, dried, stimulated, and then given an open airway. That is the initial steps. Then intervention. If the baby is not breathing or has a heart rate less than 100 beats per minute, positive pressure ventilation, that is using the ambu bag, the mask, will be applied. We have the advanced care. In the advanced care, if the response or chest compression, that is 3:1 ratio, so that one you do the chest compression for 3 times, then you press the mask, the ambu bag that you have placed on the baby. So 3 chest compression with 1 ambu bag pressing. And then medications like adrenaline may be used. We have the guideline. The guideline, we have the neonatal resuscitation program by the American Academy of Pediatrics. That is the standard book. So as a midwife or every facility needs to have that guideline to guide us when the babies are born so that we can help them to breathe on their own if there is any complication. Then when is it needed? It is typically required when newborn experience complications such as birth asphyxia or premature birth. Thank you.
Okay, I'll take from equipment. My name is Priscilla Naploki. Equipment needed: warm dry towels, bob syringe, bag and mask, size of 0 and 1, oxygen, beta heart rate stethoscope, and nasal tubes. So step 1 in newborn resuscitation. Stimulate the neonate by drying. Tactile stimulation can trigger spontaneous breathing. It is done by drying the neonates. If the neonates start to breathe or cry within 5 seconds, then proceed to routine care. That is essential care by drying, putting the baby on the flat surface, dry the baby, you do the baby's care, you do the cord care, eye care, and everything. You weigh and then you measure the um, extremity, the baby measurement. If not, if the baby didn't cry after the 5 seconds, then you stop stimulation and then proceed to step two. So step two, clear the airway. Lay the neonates on the back in a neutral position. Then avoid flexion or hyperextension of the neck, as this can obstruct the airway, just like the images you are seeing in figure 10.1. So the correct one is the first one. Yeah. Only in cases where there are copious secretions, suction gently, not too deeply, maximum depth 2 cm from the lips, and quickly in a duration of 5 seconds with a bulb syringe. Somebody continue.
Let me take from the step 3. Good evening. My name is Comfort Ntiamocham. So with the step 3, it says stimulate the neonate. You rub the back and soles of the feet vigorously but not roughly. You do not shake, slap, or hang the infant by the feet, or etc. If the neonate is having difficulty breathing or still not breathing after 5 seconds, stop active stimulation. Please, this is Patricia Akusa. If the neonate is having difficulty breathing or still not breathing after 5 seconds, stop active stimulation and proceed to step 4 and 5. So with here, if the baby is not responding in the second step, you have to rub the baby's back. We are still on the tactile, and then you also apply you touch the feet or the soles of the feet rigorously so that it will also also a form of stimulating the baby. But we do not have to shake or slap the baby like sometimes we see in our various units. And then if still the baby is having difficulty breathing or not breathing after 5 seconds, we stop. We have to bear it in mind that we are to help the baby to establish respiration within 1 minute. So from here, then we move to the step 4 if baby is not responding to all those tactile. So step 4, you clamp and cut the cord if not already done. Then we move to step 5. Step 5 has to do with performing bag and mask ventilation. Fix the mask over the nose and the mouth. That is, you have to check the size that will be fixed for the newborn's mouth and nose, so that when we are applying pressure, it will be well fitted, and then there will be well ventilation for the baby. So you press firmly to prevent air leaks. That is, you use your thumb and your index finger with the thumb at the top and the index finger at the area of the chin. You seal it well so that there will be no air leakage. Then you hold it with one hand. That is what I have explained. One side and the index finger and the middle fingers on the other side. So we have the images there. With the other hand, squeeze the bag at a rate of 30 to 60 breaths per minute for 60 seconds. Ventilation is effective if the chest rises and falls. Excessive ventilation pressure can cause pneumothorax for the baby. And if the chest fails to rise, check the connection between the bag and the mask. Correct the position of the bag, the mask on the face, and correct the head position by either extending the head slightly, then you reapply the mask. Please, so the figure 10.2 is showing us the correct way to apply the mask. So the first one is the correct one. You have to make sure the mask covers the nose and the mouth gently. And then the figure 10.3 is also showing us how we hold the bag and the mask. That is the index fingers and the other fingers down with the thumb at the top, with the right hand holding the bag, ready for ventilation. Is someone taking or I should continue? So we are continuing. Check every minute for spontaneous respiratory effort. That is, look for chest movements. Do not take the mask off the neonate face. Check for the spontaneous breathing. So whilst you are doing, you don't do it continuously. As you do breathe 1, 2, 3, you count in your head. Then you press the mask 1, breathe 1, 2, 3. Then you press the mask. Then you also check for the rise and fall of the chest to see if the baby is breathing. Then you continue manual ventilation until there is spontaneous respiratory effort. You continue until you see that the baby is starting to breathe on its own. Then maybe you stop. If it is not enough, then you have to still continue to breathe. Then we come to oxygenation. If oxygen is available, connect ambu bag to an oxygen reservoir after 2 minutes of ventilation, setting at a 2 liters per minute flow rate. Ventilation is a priority and should not be interrupted to connect the oxygen. That is, you have an assistant connect the oxygen. You only connect the oxygen when the baby has spontaneously started breathing on its own. Until the baby starts spontaneously breathing, you cannot do the oxygen connection. And then you do not have to stop the bag and mask, or you stop everything and come and connect. You have to have an assistant to help you do so. Chest compression and medications.
Let me take the chest compression, Sister Comfort.
Okay, thank you.
I'm Abigail Jabia. Chest compression is less than 60 beats despite effective ventilation. And under that, we have technique. And under the technique, we have 2 times over the sternum. Depth is 1/3 of the chest. Ratio is 3 compressions is to 1 ventilation. And the rate is 120 events per minute. And we have a diagram under it showing how you should do it. Agreed, please, next slide. Let's go, please. We have medications. If heart rate is less than 60 beats per minute after adequate ventilation and compressions, epinephrine, that is IV or intraoxygen preferred. The dosage is 0.01 is to 0.03 milligram per kilogram. The volume is if blood loss is suspect kilogram isotonic fluid, and you have thermal management.
Please let me continue with the thermal management.
Oh, okay.
Hello. Thermal management. Keep warm after resuscitation. So you have to keep the baby warm after resuscitation. Then you use a warm blanket, a radiant warmer, and a plastic wrap for extremely preterm infants. So baby who are preterm, you give them a warm blanket or you put them under a radiant warmer or a plastic apron to keep them warm. Then hypothermia increases mortality. So if the baby is exposed to too much cold, the baby will die or we will lose the baby. So we make sure we keep the baby warm. Then common pitfalls and troubleshooting. That's check MR or SOPA, mark seal, reposition away, suction mouth or nose, open mouth, then pressure increase, then alternate airway. NB, if ineffective, consider intubation.
Okay, so please let me explain this part a bit.
Okay.
Mr. Super, this is an acronym that we use to continue to resuscitate the baby. When we are doing the bag and math, but it is failing, then we have to use the Mr. Super to increase or improve ventilation for the newborn. So if the mask is not well fixed, we have to reapply the mask. That is for the M. Reapply the mask well, and then we have to check that it is well stitched. And then we have to reposition the baby. Let's say if the baby is hyperextended, the head is hyperextended or it is flexed, the airway may be blocked, so we have to reposition the baby. And then we also have to suction the baby's mouth and nose for if there are visible secretions, and we do it gently not to hurt the baby. Then we have to make sure the mouth is well open before we apply the mask. And then we have to increase the pressure and from the back that we are pressing. And then we alternate the airway, that is extending the head a bit or something. And if it is ineffective, still there is no improvement, then we consider intubation. Thank you. Somebody should continue. So in summary, warm
summary, warm position, clear airway. So first the baby's airway, then secondly, if needed. Please, I'm reading. No. Oh, my network.
Continue.
We are hearing.
Okay, so
Hello.
summary. 1.1 warm, position and clear airway. Then you stimulate, that is, you ventilate if needed. If effective, PPV first. Then you add compression if heart rate is less than 60 beats per minute. Then you consider medication after adequate ventilation. So these are the items needed. Then our references. Thank you. I'm Josephine.
Okay. Please, any question or contribution?
Hello, it's Petra. Please, I want to ask a question.
Okay.
Please, I would like to know how many minutes we have to resuscitate the baby. I mean, when you are bagging, is it that you are going to do it you are going to do it for an hour or 20 minutes or 30 minutes before the baby will regain its consciousness? I want
Hello,
to
class.
know.
Hello, this is Esther, and please, we have a video on this resuscitation, so let's watch it. Then after that, you can ask this question. Thank you.
Please, as we are waiting for the video to play, please let me answer the question the sister asked earlier about the minutes for the resuscitation with the bagging. You bag for 30 seconds to 1 minute until baby establish respiration. So after that, and baby still not crying, then you add the chest compression or intubation. Yeah. Please, I hope
Okay,
I've
thank you.
answered your question. Yeah. Okay.
Yeah, thank you.
When you come to work, you have to prepare for birth. And in preparation for birth, you have to set up the resuscitation area for ventilation. You have to clean the area, you wash your hands, and then you wear. When you come to work, you have to prepare for birth. And in preparation for birth, you have to set up the resuscitation area for ventilation. You have to clean the area, you wash your hands, and then you wear your sterile gloves. Then you have to get your 2 sheets. You have to get your surgical glove. You have to get the baby care, 4 clamps, 4 scissors. You have to check your stethoscope. You have pediatric stethoscope if it is small. And then you have to get the mask. The mask, you have to get size 1 and then the size 0. Size 1 for 10 baby and a size 0 for preterm baby. And then you have to check your back if it is functioning well. So you put the mask on the ventilator. You put the mask on the ventilator bag, then you squeeze the bag. As you squeeze the bag, you look for the valve. So the valve is inside. And then you check through the valve if it is opening as you squeeze. If the valve is opening as you squeeze the valve. This shows the device is ready to deliver air to the patient. And then you put the mask tightly in the palm, and then you squeeze harder. You squeeze harder. Enough to open the pressure valve. That's the pressure valve. So you listen to the sound of the air escaping. So this shows that air which cannot be delivered safely to the baby
will escape through the pressure relief valve. So you maintain a tight seal and check the bag re-inflate after each squeeze like this. This shows that air will enter the bag through the inlet valve. So you keep the mask sealed against the hand. Press the pressure relief valve down the bag and check that there is no leakage. So this one, as you check, there is no leakage. And then you check your suction device if it is working well. So you open, you check inside if there is no dirt, water and cracks. Then you close it. You place it in the palm. You squeeze and place it in the palm. As you do that, you see that it will take a longer time for it to deflate. It means it's working properly. So we have checked our equipment. So we are now going to deliver our baby and resuscitate our baby. To deliver our baby. So you wipe the baby. My baby is not crying, my baby is not breathing. So I will stimulate the back. So my baby is not crying, my baby is not breathing. So I'll check for secretion. There is secretions in the mouth. So I'm searching for secretion. So my baby is not crying. So quickly I'll climb and cut the cord and send the baby to resuscitation area and start to ventilate. So with the ventilation, when we are coming to ventilate the baby, you make sure you cover the baby from the chin to the bridge of the nose. From the chin to the bridge of the nose. And you use your thumb and then the index finger to support. So you have to make for resuscitation, you have to make a firm seal. In making a firm seal, you have to place the mark from the chin to the bridge of the nose. You shouldn't cover the eye of the baby with the mouth open. So you use your thumb and then the index finger to support the top, and then you use your middle finger to support the chin. It will help you to extend the head. Then you start to ventilate. With the ventilation, it's supposed to be 60 to 30 to 60 breath per minute for 60 seconds. So breathe 2, 3, 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 breathe 2, 3. So when you make a firm seal, you can ventilate without inflating too much air into the baby. So you don't inflate it like this. You don't do it like this. But you make a firm seal, then gently you inflate like this. So you will see the rising of the chest. Breathe 2, 3, breathe 2, 3, breathe 2, 3. So breathe, then you squeeze 2, 3, then you release. Breathe 2, 3, breathe 2, 3, breathe 2. With this, our baby is crying. But when you ventilate and then still the baby is not crying, you have to reapply the mask. And then you turn the baby head, you check for secretions, and then you suction. And then you open the baby mouth wider, and then you extend the head, and then you squeeze the bag harder. Breathe, 2, 3, 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 breathe, 2, 3. So if no breathing, you check for heart rate. If the heart rate is normal and the baby is still not breathing, then you continue ventilate, and then you decide on advanced care. If the heart rate is low, so you continue to ventilate, and then you decide on advanced care. But if the baby heart rate is normal, the baby is breathing well, you monitor the baby with the mother, you continue skin to skin and monitor the baby, and then you help initiate breastfeeding. Thank you.
Please, any question or contribution?
Hello.
Yes, please.
Please, I have a question.
Okay.
Is it still advisable to flip the baby stool when baby is not breathing properly or not breathing at all?
We said that you can touch the baby so gently, like you give it a gentle massage, not like to give the baby pain or anything. Thank you.
Okay. Yeah, okay.
Please, any question again? Then the next group should present.
Hey.
Hi,
I'm too lovely.
Sister Tina, please mute yourself.
Please, the next group can present.
Good evening, sisters. Please, we are group 2 from Tamale Center.
Good evening.
We are presenting on baby of a diabetic mother. For definition, root. A baby of a diabetic mother, that's IDM, is a newborn delivered to a woman with gestational diabetes, that's type 1 or 2 or type 2. gestational diabetes mellitus, hypoglycemia. So let me explain it. So we are trying to say that with the diabetes, we have type 1 and type 2. And when a woman who has any of them gives birth to a baby, the baby is prone to having diabetes. So hypoglycemia refers to a low blood sugar concentration. Infants of diabetic mothers should maintain a blood glucose concentration of 2.6 millimole per deciliter or above. Background and pathophysiology. With
Sister Ruth, please take it
insulin-dependent
from here.
diabetes mellitus, maternal hyperglycemia
Please
or
let me take it from here.
hypoglycemia and ketosis can occur during fetal organogenesis, and there is increased incidence of fetal anomalies. Careful attention and preconception control of diabetes decreases a risk of anomalies. With gestational diabetes, because glucose intolerance does not occur during organogenesis, the risk of anomalies is not increased. Please, I will explaining. Glucose transport across the placenta is not limited. Fetal hyperglycemia stimulates beta cells hypertrophy. Increased insulin production and fetal oxygen consumption. Insulin has mitogenic and anabolic effects on many tissues. Example, adipocytes, skeletal and cardiac muscles, hepatic and connective tissues, but not brain. Therefore, delivery of IgM may be complicated by large shoulder and abdomen, large shoulders and abdomen that can cause dystocia. The presentation cannot be seen. Hey, please hold on, I'm coming. Please, can the presentation be seen?
Yes.
Yes, it can be seen.
Hello?
We can
It
see
can
it
be
too.
seen.
It can be seen.
Yes, we can
See.
see.
Please, if they can't see, somebody should project it because me, I'm using my
Please,
phone. I don't know
Ruth,
why they
Ruth,
said they
we
can't
can
see.
see. We can
We
see.
can see it
Continue.
clear,
Go
please.
on, we
Hey,
can see,
who are
please.
those saying they can't see? No. Jonathan.
Saru, please share it. We can see. I don't know those saying they cannot see.
Ruth, you can share your screen. Oh, it was clear, so please share and then continue.
One six. They got yeah.
Natural master interconnected. And now open internet. Actually, no problem.
Please, we are still waiting for you guys.
Please, the one sharing your screen is not clear, so remove it and the other person will share and will do it.
If you're already, please remove your screen so that they can share for us to see.
Madam Eva, please remove your screen.
Oh, the time is going.
Please, somebody should call her.
Ivaredu,
It's
kindly stop sharing your screen so that we would share and then continue. We have less than 30 minutes left.
Please, if you can't take it off, you leave and come again.
If you don't stop sharing, they cannot share theirs to present. If you are sharing too, kindly do so that they just present,
Here,
please.
leave. When I leave, the thing will close.
Ivaredu.
It gives me, I can't share while other participant is sharing. So unless the person remove this thing. Arin also. You are blocked.
Please, which center is Eva? Somebody should call her to just remove it so that they continue, please.
She doesn't understand.
She's like me.
You have a number. Kindly share it so that I call her to stop sharing, please.
The co-host should take care of. Should take care of.
They should take care
so
of.
that they can share.
Yes.
Benne, please, can you just take care of so that they can share for us? Benne, remove Eva.
By now, she's not even aware her screen is like this and she's somewhere.
Ruth, kindly start sharing your screen.
Please, at Sanko Center, I have shared the screen so we can start.
But they were already doing it, so I think
But
they
we
should.
started, we are not done.
They started, so let them continue. Ruth, please, you can share your screen now.
Hello, sorry. Those who are presenting, those presenting now, the one who was sharing the screen. I'm at a very noisy area. So that's why I've muted myself for this one. So I have to leave that area.
Hello, sisters. I don't know if we still have the time to present. So I'm going to
No,
explain
you
what
don't
I
have time. We
read
are
earlier.
looking at.
So all that
Is it not?
the
Where's
slide
Petram?
one is trying to tell us is
Sister,
that
please, I'm here.
glucose
Why?
from the mother will move freely
We have 18 minutes.
with a diabetic mother. When pregnant,
Where's
glucose
Petram?
will move
Sister,
freely
please,
along
I'm here.
the
Ruth,
placenta
please.
to the fetus.
Who are those
So the
presenting?
placenta will allow the glucose to
Ruth,
pass through
please.
facilitated diffusion. Then the fetus
Ruth, can't we
cannot
hear
control how
anybody?
much glucose enters
Ruth,
into
they are
the
calling
Ruth,
you.
comes to
Ruth,
the fetus
Ruth.
itself
Petra,
because
mute
everything is being
her. Just mute
transported through
her
the
and
placenta.
listen to what
Oh,
sister
what
is
I
The
can
saying.
glucose level depends directly on the mother's glucose. The baby's glucose level will
Is it?
directly depends on the mother's glucose level. So what this is trying to say is that if the mother has high blood sugar, which is hyperglycemia,
Bella,
the
please
fetus
mute
will
her.
also develop high sugar level, which is fetal hyperglycemia. Please, do we understand?
Ruth.
Ruth, stop talking. Why? Sister is talking.
Hello, Ruth.
please, I've muted her.
Ruth.
Please, she's been muted.
Hello.
Ruth, you don't want to respond. We have limited time. I was at a noisy environment. So that was why I muted myself. So if the other group have finished presenting, you don't have to share your slide and start presenting. Looking at the time, what time are we supposed to close, Petram? What time are we supposed to end the class?
7:15.
Okay, so 7:15.
Yes, please.
Present 7:56. That means we have 15 minutes. Why don't we do some discussion? It's far better. Why don't we discuss about the forthcoming midterm? Isn't it far better than you starting to present? I've been calling you Ruth. You still don't mind me.
Sisters, I'm sorry. I didn't see my screen. Sorry. I didn't know.
No, you didn't see your screen, but at least you were hearing us. Everyone was calling you Ruth. What is it?
I'm sorry. I didn't hear.
That's fine. So you present God willing next week. How many groups are we left so far? Hello, Petram.
Yes, sister.
How many groups so far?
I would have to check and get back to you.
All right. So let's discuss the forthcoming mid-semester. So with the mid-semester, you'll be having about 30 questions. 30 questions, and then you'll be having about 30 questions, and then you'll be using 20 to 25 minutes to answer. I'm yet to decide on that. But I've seen that Petram is sending me a message to make it 30 minutes so that you have the time and chance to Google.
No, please. No, sister.
No, sister.
No,
Petram, why are you
Children of
soliciting
God
for
don't
30
copy.
minutes?
Please.
Sometimes the network.
Who said
Some
you
of
are
us,
children of God?
our network is not good.
No,
So
you see, the thing is, if you are all children of God, you are supposed to be 1,000 here, but you are 539. You are 539. If you were really children of God, you would have come to class. So, I've decided to make it 25 minutes so that you not get the time to copy. I mean, 20 minutes. I have not.
Sister, please, we beg. At least 25 minutes is okay.
Make it 30 minutes. We beg.
I make it what?
2 minutes, please.
One minute. So I'm not going to check whether you copy or not. And even if I ask you all to open your and then do it, sample will still copy. So what I'll do is You will do it within a time space of 25 minutes. And then okay, so around that 25 minutes, or if you're not able to finish, fine. If you're able to finish, it means someone was doing this for you. Okay. All right. So let's say we are going to, with exams, it will comprise of what do we call it? It will comprise of the low birth weight, large for gestation, and then small for gestation or light for gestation, and then we'll do asphyxia as well. Any question? Because I think for what you've presented so far, I will come in a little. I'm not around. That's why I couldn't give you my own slide. I'm not around. I've traveled. So even with call, I don't know how many people have called me, but I know Petram has called. Petram, did it come?
No, please.
It just came because Bibintinaba. But with the previous days, if you had called, it wouldn't have come. I'm not around. I've traveled. Yes. So what we'll do is that Petram said we should do it. We should do it on Wednesday. I think that's the what the class decided. So we'll do it on God willing Wednesday. So I'll communicate with Petram before that day gets near. Any question?
Yes, sister.
Yes, I'm listening.
Sister, please. We beg you in the name of some of us are not bad. We even suffer to the extent we are in class. If you can do it, yes, we will really appreciate it.
Into the crack.
Sir, please. The time should be 30 minutes. Please, I'm pleading.
Is 30 minutes. You see, if I give you 30 minutes, most of you will copy. So I've even decided to make it 20 minutes.
Oh, sister, please. We will not copy.
Ah, so you want to tell me this for me to believe you or trust you? Hey, Petram. Is it not Petram?
Yes, please.
Yes, Petram. You want me to trust you with this? So it's like putting a fish closer to a cat and telling the cat that don't eat. The cat says, I won't eat. He said, okay, don't eat. Oh, Petram. I know most of you will copy. I've been a student a number of times, so many times. So many times. No. I'm saying that I've been a student, so I know what students can do. So me, for my questions, you never get any pass. My questions, I don't throw pass. I've been a student number of times. I don't know whether it was this class that I told you. I started as a ward assistant in 2007. Ward assistant to enrolled nursing to post-basic midwifery, and then on and on and on and on. And then by God's grace, we are here. So I've been a student many times. So I don't expect a student to tell me that, oh, we won't copy and then I'll believe the student. No. If I'll believe you, then I'm just trying to say that, oh, go and copy. So I know you. I've been a student many times. I know you. I know what students can.
Just believe us.
Who should believe you? So that I'll let you go and copy. It is well with you.
So please, it's not like that. The next week will not favor some of us. Please, we are pleading.
The what? I didn't get the one who
I'm talking about the network. Sometimes you log in and the network will be whining for some time, please.
So go to a better place. You see, when I have class with you, it's quite unfortunate that this time we didn't meet on Saturday. But my class used to be Saturday very early in the morning, around 7 to 9, and then 9 to 11. So it's quite unfortunate that I'm not able to meet you this time around at 7. You will see that in the morning I'll be running helter skelter to get a better place for you. This time is not favorable for me. I've told the IT personnel, but I think they said, though they asked me when I wanted, but I think I told them about the regular, so I didn't tell them about this one. That's why I think they placed me here. But you have to go to a better place, because if the network locks you out, then you are out. You are out. So it is well with you. Say amen.
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 Sister,
Amen.
please, now is it going to be?
Amen.
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 So it's going to be MCQs. It's going to be MCQs, right? MCQs.
Okay,
Yes.
sister, thank you.
MCQs. Oh, you don't want MCQs?
We want.
Objective.
Sister, we are only
You
working
get
on what we
MCQs.
want most.
Okay. Okay. Oh, I should give you theory, 3 theory.
Please, no.
Okay, so it's
No,
going to
please.
be MCQ. At the end of the semester, you have 120 objectives, and then a theory, pregnant with grandchildren and grandmothers. Are we together?
Yes.
Yes, sister.
So with the end of semester, you have a 120 MCQ with theory. 20 marks for theory, and that 20 marks for theory is not easy to get that 20, because you have a young person, grandfather, young person's grandmother, grandfather, children, grandchildren, and great grandchildren. Yes. So that's how it's going to be. It's like 30%. I don't know, 30 or so, you see, but it's over 30, so it's mixed up. So what your friend will have might not be the same as what you will have. Okay. All right. So let me
Sister, please, time.
check if these people are around. If no friends here, aside those who presented, there are some people I always then they are present because they are always let's call some whether they are there. Some are here, but they are not here. So let me see. What's the name? Where's Joyce Tino? Where is Joyce Tino? Where's Joyce Tino? Okay, Joyce Tino is here. Where is Sabia Tibu Rahel? Hey, you're
Hello, sister.
Okay. Where is Edufa Ramat? This is second time or third time I'm calling and he's not responding. Where's Edufa Ramat?
Yes, sister.
Okay. Where's Wendy Anima?
Yes, sister.
Where's Comfort?
Yes, sister.
Comfort. Okay. Who else?
Yes,
Who else?
sister.
Let me see. Okay, so Belinda, where are you? Belinda. Belinda. Okay, where is Giftiando?
Yes,
Giftiando.
please, I'm here.
All right. So let me see. All right. Francisca, sorry, Francisca J. Francisca J. Okay. This shows that you are really prepared for the exams, right? For the midterms.
Yes,
No, that's good. That's good. All right. So let me see. Abigail Dachom. Abigail. Abigail.
Yes, sister. Yes, sister.
Yes, please pray for us to end the class. Please pray for us to end the class. But I don't want Garden City to end that. I want us to end before they come in. Abigail, are you praying? Okay.
Let's pray.
If Abigail is not praying,
Let's pray.
Abi, you are praying, but I can't hear you. Pray. I can hear you, man.
Heavenly Father, we thank you for we pray that whatever was taught us to stick into our mind on the day of exam, we will be able to do everything successfully. In Jesus' name, amen.
Amen. So the Lord be with
Amen.
you all. Not to talk
Amen.
to Trump before the time comes, the time for the midterm comes, and then she will communicate everything to you. The Lord be with us all and keep us safe. Have a good evening and a nice weekend. Bye-bye.
Bye.
Thank you, sister. God bless you.
Thank you, sister. Bye-bye.
Bye.
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 Bye.